Clinical correlate, multiple sclerosis. In the anatomy lecture, the function of oligodendrocytes is discussed. Oligodendrocytes myelinate neurons in the central nervous system. Multiple sclerosis is a disease that affects the myelin sheaths of the CNS neurons, leading to focal areas of demyelination and neuronal loss. Take a moment to read the following clinical vignette. This 26-year-old woman presents to the clinic with diplopia and pain in her eyes during the last 4 hours. She had similar episodes in the past, especially after exposure to high temperatures. Although these past episodes resolved on their own, on this occasion, she is also experiencing sensory disturbances in her legs and difficulty walking. On examination, she has increased muscle tone and a power of 3 out of 5 in both lower extremities. Deep tendon reflexes are brisk, and she has bilateral upgoing plantar reflexes. These findings are consistent with lesions involving upper motor neurons, which arise in the brain and descend into the spinal cord as the pyramidal tracts. The presence of altered sensations in her legs suggests involvement of the sensory system as well. Fundoscopy shows inflammation of the optic disc, indicative of optic neuritis. This inflammation causes pain and impaired color vision. The defective horizontal conjugated gaze described in the vignette is referred to as internuclear ophthalmoplegia. This condition develops due to a defect in a bundle of neurons known as the medial longitudinal fasciculus, or MLF. The MLF serves to connect the abducens nucleus on each side with the contralateral ocular motor nucleus. This connection allows for conjugated eye movement when both eyes move together in order to focus on one point. Now, if the MLF is disrupted on one side, the ipsilateral side is unable to adduct, causing the patient to have double vision. This patient has bilateral involvement of the MLF because she is unable to move the adducting eye on either side. The lesion responsible for these findings could be located at any level from the cortex to the spinal cord tracts. Bilateral cortical lesions are extremely rare because the right and left hemispheres are anatomically separated, each with its own blood supply. Moreover, simultaneous involvement of the sensory and motor systems is unlikely to originate in the cortex. Internal capsule lesions can give rise to sensory and motor symptoms, but bilateral lesions are very rare. The symptoms in this patient could be indicative of spinal cord pathology like cord compression or shringomyelia, but spinal cord lesions will invariably show a distinct level of demarcation corresponding to the lesion. In addition, involvement of the optic nerve and MLF cannot be explained by a structural pathology of the spinal cord. Multifocal CNS symptoms that occur distinctly over time are suggestive of a demyelinating disorder such as multiple sclerosis. Clinical features alone are insufficient for diagnosis. An imaging study such as an MRI or laboratory tests such as CSF analysis must be performed. As with all patients showing signs of neuropathy, levels of vitamin B12 and an RPR to screen for syphilis should be performed as well. Given this patient's age and her presentation, multiple sclerosis is an important possible diagnosis to consider as a cause of her condition. This clinical correlate has 5 learning objectives. 1. Define multiple sclerosis and review its causes. 2. Describe the pathophysiology of multiple sclerosis. 3. Identify the clinical manifestations of multiple sclerosis. 4. Recognize the tests used to diagnose multiple sclerosis. 5. Discuss the treatment and prognosis of multiple sclerosis. We will begin with our first learning objective to define multiple sclerosis and review its causes. Multiple sclerosis is an autoimmune inflammatory disease of the central nervous system characterized by focal areas of demyelination and subsequent reactive gliosis. It's one of the most common neurological diseases in the United States, affecting more than 300,000 people. Women are affected twice as often as men. The etiology of multiple sclerosis can be attributed to many factors, such as genetics. Now, although MS, or multiple sclerosis, is not considered a hereditary disease, its incidence is higher in family members of affected individuals compared to the general population. HLA-DR2 has a strong association with multiple sclerosis. Environmental factors. Now, a number of environmental variables have been linked to multiple sclerosis, but the evidence is not confirmatory. Some of these include decreased sunlight exposure with subsequent decreased vitamin D production, severe stress, smoking, occupational exposure and toxins, and low levels of uric acid. Infectious causes. Viral infections are proposed to be a precipitating event for an autoimmune response against myelin sheaths. Notable viruses include herpes simplex, measles, mumps, and rubella. Let's turn our attention to our second learning objective and describe the pathophysiology of multiple sclerosis. Multiple sclerosis is believed to be an autoimmune disease directed against the myelin sheaths of neurons in the central nervous system. Various environmental factors, particularly viral infections, alter blood-brain barrier permeability and subsequently cause leakage of T cells and other inflammatory mediators into the cerebrospinal fluid. Now, after the inflammation subsides, the blood-brain barrier once again becomes impermeable and the leaked T cells become trapped inside the brain. These T cells may evoke an autoimmune response against different kinds of proteins. One of the proteins involved, myelin basic protein, is of importance because it's an integral part of the myelin sheaths. Self-reacting T cells against myelin basic protein have been recovered from the serum and CSF of multiple sclerosis patients. Moreover, experimental allergic encephalitis, or EAE, has been produced in laboratory animals injected with myelin basic protein. The presence of oligoclonal bands, which are IgG immunoglobulins in the CSF, further suggests autoimmune-mediated destruction. The function of myelin is to insulate axons, which is necessary for rapid transmission of neuronal impulses. Oligodendrocytes are glial cells, which myelinate axons in the central nervous system. Gaps in the myelin sheaths, known as nodes of Ranvier, enable saltatory conduction of impulses. Saltatory conduction is characterized by quick transmission of an impulse from one node to another without depolarizing the intervening myelin portion of the axon. In multiple sclerosis, the autoimmune inflammatory response leads to phagocytosis of myelin by macrophages. This affects the speed of neuronal transmission, leading to a conduction block or very slow impulse propagation. The oligodendrocytes attempt to remyelinate the affected neurons, but the repair process is never complete or effective. Continuous or relapsing chronic inflammation results in lesions that eventually cause axons to degenerate, leading to permanent neuronal loss. These neurons are replaced with glial tissue, analogous to a fibrous scar in other parts of the body, forming a plaque-like structure around the destroyed neuron. On gross and microscopic examination, the foci of inflammation and demyelination are usually seen around venules, an arrangement known as perivenular cuffing. Multiple sclerosis usually affects the white matter of the brain near the ventricles, brainstem, and basal ganglia. The optic nerve is the most commonly affected cranial nerve in multiple sclerosis. It's important to note that multiple sclerosis spares the peripheral nervous system because peripheral nerves are myelinated by Schwann cells. Let's identify the clinical manifestations of multiple sclerosis as our third learning objective. Multiple sclerosis usually presents with a broad spectrum of clinical features. Neurologic deficits occur at different times during the course of the disease and point to multifocal involvement of anatomically non-contiguous structures of the central nervous system. Symptoms include altered sensations, which are by far the most common presenting complaint. These include paresthesia, like burning, tingling, or numbness, hypoesthesia, which is decreased sensation, dysesthesia, which is an unpleasant sensation due to common stimuli, acute and chronic pain syndromes, trigeminal neuralgia, and Lermite sign, which is an electrical sensation running down the back or an extension of the neck. Visual disturbances, which include pain and loss of color vision due to optic neuritis, as well as diplopia due to abducens palsy or internuclear ophthalmoplegia. Again, this is caused by damage to the medial longitudinal fasciculus. The MLF connects the abducens nuclei to the contralateral oculomotor nuclei, thus enabling lateral conjugated gaze. During an attempted lateral gaze, the adducting eye on the side of the lesion remains in the middle, while the abducting eye on the opposite side shows nystagmus. As shown in the diagram, in the left internuclear ophthalmoplegia, the left eye doesn't move if both eyes try to look towards the right. Conversely, the right internuclear ophthalmoplegia, the right eye does not move in an attempt to look towards the left. Such disruptions cause patients to experience double vision due to a lack of coordinated, or in this case, conjugated eye movement. Motor weakness frequently results in significant disability. Other motor symptoms include spasticity due to involvement of upper motor neurons, dysarthria, which is difficulty in speech articulation, and dysphagia, which is difficulty in swallowing. Ataxia and tremor are present due to cerebellar involvement. Cognitive impairment can occur due to neuronal degeneration. Mood disorders such as depression are also very common. Suicide rates are higher in patients with MS as compared to the general population. Increased intensity of all symptoms on exposure to elevated temperatures. Signs of multiple sclerosis are nonspecific and are in accordance with the underlying pathology. Involvement of motor spinal tracts yield upper motor neuron signs such as spasticity, motor weakness, brisk deep tendon reflexes, upgoing plantar responses. Involvement of the sensory tract can manifest as altered sensations. Fundoscopy shows a swollen optic disc with blurred margins during an attack of optic neuritis. Cerebellar signs can also be present, such as drunken gait, pendular knee jerk, and intention tremor. The course of the disease has been classified into the following 4 patterns. Relapsing remitting. This is the most common pattern and is characterized by distinct attacks or flare-ups, which may or may not leave residual deficits. These episodes are followed by periods of remission during which no new disease activity is seen. Primary progressive. Patients with this pattern have a steady progression from the onset of the disease without any distinct attacks or periods of remission. Secondary progressive. Now in this pattern, there is initially a relapsing remitting course that deteriorates into a steady progression without periods of remission. Progressive relapsing. This is the least common of all patterns. It's characterized by a steady progression from the onset of the disease with superimposed distinct flare-ups. Let's describe the tests used to diagnose multiple sclerosis as our 4th learning objective. There's no single diagnostic test available for multiple sclerosis. Therefore, it's diagnosed by documenting clinical radiologic, and laboratory findings. Clinical diagnosis of multiple sclerosis can be made in patients with a history of distinct attacks associated with symptoms suggestive of CNS disease in at least two anatomically non-contiguous areas. Since most patients seek medical attention after initial attack, the diagnosis of MS can be made difficult to reach clinically. In such patients, diagnosis is confirmed by using testing modalities such as magnetic resonance imaging, CSF analysis, and documentation of evoked potentials. MRI of the brain and spine can be used to show foci of demyelination. Gadolinium is used as a contrast to highlight the active plaques to differentiate them from older lesions. Normally, gadolinium is unable to cross the blood-brain barrier, but in areas of inflammation where the blood-brain barrier is permeable, gadolinium is able to enter and effectively highlights active lesions. CSF analysis shows mild pleocytosis. Electrophoresis reveals the presence of oligoclonal bands, which are formed by intrathecally produced IgG. Visual or sensory evoked potentials can also be helpful in making the diagnosis. When white tracts are demyelinated, conduction of an impulse is either blocked or extremely slow. This can be demonstrated with the help of electrodes recording potentials from affected parts of the brain after visual or sensory stimulation. Let's discuss our fifth learning objective, the treatment and prognosis of multiple sclerosis. Now, as there is no definitive cure available for MS, management is aimed at the following objectives. 1. Resolution of an acute flare-up or attack. Acute exacerbations are treated with the help of high-dose corticosteroids such as prednisone. Their anti-inflammatory effect dampens the acute inflammation, but they do not have a role in preventing future attacks or in altering the course of the disease. Corticosteroids are only used for a limited time in order to avoid the adverse effects associated with their long-term use. 2. Prevention of new attacks. Now, prevention of new attacks can be done with the help of disease-modifying drugs such as beta interferon, which helps to reduce frequent exacerbations by exerting anti-inflammatory effects. Beta interferon is thought to diminish immune response by activating suppressor T cells. Glatiramer, an immunomodulator, is used to redirect the immune system away from myelin. It's a polymer made up of a similar structure as that of myelin basic protein. Metoxantrone, an alkylating agent, is a chemotherapeutic drug that is toxic to immune cells, which makes it effective in reducing flare-ups. Natalizumab is a monoclonal antibody against integrins. Integrins, a class of complementary molecules on the endothelial cell surface, assist in the adhesion of inflammatory cells before they migrate outside of the bloodstream. Natalizumab has been associated with the development of PML, progressive multifocal leukoencephalopathy. 3. Treatment of complications to improve quality of life. Complications of multiple sclerosis are usually debilitating and socially isolating. Spasticity can cause significant disability. Physical therapy and exercise can be helpful in this regard. Baclofen, a GABA-B agonist, and tizanidine, an alpha-2 adrenergic agonist, are skeletal muscle relaxants that can be used to reduce the spasms. Anticonvulsants can be used to treat neuropathic pain. Gabapentin, pregabalin, and carbamazepine are quite effective. Bladder dysfunction should be assessed with the help of urodynamic studies. Urinary retention, caused by detrusor sphincter dyssynergy, can be managed with bethanechol, a cholinergic agonist. Intermittent self-catheterization reduces the incidence of urinary tract infection. Depression can be treated with the help of SSRIs, such as fluoxetine, or tricyclic antidepressants, for example, amitriptyline. Propranolol, or clonazepam, can be used to control ataxia and tremor. Now, the prognosis of multiple sclerosis varies amongst patients. Some of the factors which predict a relatively better prognosis include onset at a younger age, female gender, 2 or fewer attacks in the first year, relapsing remitting pattern of the disease, optic neuritis, earliest presentation with sensory disturbances as compared to motor or cerebellar signs. Regardless of the prognosis, most patients eventually suffer some degree of disability, especially ambulatory. Multiple sclerosis rarely is a primary cause of death. Most patients suffer from secondary complications that prove to be fatal, such as infections. Suicide is also an important cause of death in such patients. Let's return to our vignette and apply what we've just discussed. This patient is suffering from internuclear ophthalmoplegia, a common manifestation of multiple sclerosis. So, a lesion of what structure is causing defective horizontal conjugated gaze in this patient? Internuclear ophthalmoplegia develops if the MLF is disrupted by the disease process. The eyes are unable to gaze horizontally in unison, giving rise to diplopia. Therefore, involvement of the medial longitudinal fasciculi on both sides gives rise to defective horizontal conjugated gaze.